The next presentation is Dr. Abhijaat Chaturvedi. He will be talking about OCTA, a prolific speaker and a young ophthalmologist, budding ophthalmologist.
We're still budding. In front of all of you, I'm still budding. So very good morning to everyone. Why I chose to speak just on octa, because I feel just like suprachoroidal injections, octa is something which is an underdog in the field of investigative retinal diseases. So octa is something which is very important, a diagnostic tool, a patient education tool, and how can you use it in various diseases which include neovascularization. I'll just show you that. So coming on to the commonest pathology which we encounter in OPDs is diabetic retinopathy. Now what do you see in diabetic retinopathy? So the red arrows, they show some small white dots. These are nothing but microaneurysms. Now, why you need to know this? So the image on the left, the patient clinically showed no signs of diabetic retinopathy. And this patient was sent away that, no, you don't have diabetic retinopathy, come after 1 year. But as soon as you do an octa, you can clearly see that these red arrows are showing CNP areas. These are capillary non-perfusion areas. And this is a microaneurysm, and this is a microaneurysm. So this patient is having mild NPDR. So maybe you'll start an anti-inflammatory drop, do a systemic workup, and maybe call him back in 6 months or something. So since this is a non-invasive tool, and you can see these are beautiful images of NVDs and NVEs, which can be recorded. Similarly, this is another image. It shows neovascularization elsewhere. So how do you identify that this vessel is having neovascular tissue or component or not? So when I zoom this image, you can see that the caliber of the vessels changes. So apart from the surrounding CNP or non-perfusion, you can see that the vessel, the neovascular tissue is broader. It has more fluorescence. So that is somewhat a identifying feature of neovascular tissue. So these both the photos, the purpose of putting them here was that when you do an FFA, you just study the superficial layer, what's happening there. But with octa, you can study the superficial layer, the deep layer, the outer layer, even till the choriocapillaries. If you just do an OCT scan, you can see that there's a B scan image here. You'll see whether there's edema or not. But how deep the pathology is going on and the depth of vascular disruption can be beautifully studied using this investigation. And this will help you in determining the prognosis and how your treatment course alters. So this is something which is happening normally also. There are flow voids in choriocapillary area in the octa, but in diabetics, these just coalesce and become a little larger. So this is my patient of vein occlusion, and OCT findings, we all are aware about that. Now, why do you need to do an octa here? So if you do an FFA or if you just see this B scan image, you can see an edema here. This is the superficial scan. And it shows that, yes, there is flow void. But this is actually not a flow void. This is just edema that is masking. Now, when you go to the outer scans or the deeper scans, you actually start to see the non-perfusion areas. See how the non-perfusion is increasing. And since it's going to the level of choriocapillary, this determines that this is an ischemic type of vein occlusion and not a non-ischemic type. You can also quantify this perfusion. And this is what I'll show in this slide. So these values show the vessel density and how the vascular perfusion is there in that area. And you can do that for all the levels. And why do you need to do that? So this patient was injected with aflibercept, and after 5 weeks, the edema has gone down in B scan. So this looks a pretty good image, okay? And this was before the injection. This is out after the injection. Now, the quantification about which I told, why do you need to do that quantification? That I'll show you. So on the left side is pre-injection, on the right side is post-injection. So you can see that values here, like this was 36, now this has become 44. So the perfusion is increasing. And similarly, grossly if you see, this was the entire area of non-perfusion and it is slowly regressing. The revascularization is coming back. And this is something which is helpful for yourself also, and you can educate the patient also. See, the injection is showing effect. It is getting revascularized. So this was a case published. This is a very rare thing, which is a triple cilio-retinal artery sparing CRAO. See the amount of non-perfusion. So the patient was sent for cardiology workup and a cardiology treatment. A stent was placed, and after that, see the beauty. It has vascularized. Though the vision doesn't improve much. Why? Because this entire area goes atrophic. Though revascularization and reperfusion happens. Similarly, this is a case of old STBRVO. Now, the patient has high blood pressure. I don't want to inject a dye. I don't want to do an FFA. So here comes the role of octa. You can observe neovascular tissue over this area. And then you can proceed with the injection. However, if you do an OCT-B scan, it shows that there is no edema. So why would you like to go for an injection? No. In dry RMD per se, there's not much role of octa. It will just show you a masking effect because of presence of drusen's in the choriocapillaries. However, in wet RMD, so this is a beautiful image. In the deep and in the outer and the choriocapillaries, these white areas are nothing but geographic scars. I'll still do a injection in this patient. Why? So if you observe the superficial and deep layers, you can see something is happening here. Some new tissue is developing here, which is approaching the fovea very rapidly. So just for this sake, I would go for an injection in this patient. And again, you can show this. And after injection also, you can observe this thing. It is a beautiful modality to differentiate between type 1 and type 2 CNV. So like the image on the left is a type 1 CNV, which occurs below RP level. So you can see at the level of superficial, there is no CNV net. This is the deep layer. This is the outer layer, and this is the choriocapillaries, where all in three you can observe a presence of CNV net. This is type 1 CNV. In type 2, you can see that there is some net, some CNP area, even in superficial, the deep, the outer. This is not flow void. This is again a masking effect because of presence of intraretinal fluid. There are variety of CNV net patterns like C-fan, medusa head, tangled, prune tree. Why do you need to know all this? You need to know all this because with injections, the CNV net actually regresses. And you can document it with octa. I'll show you one last case, which is again a published case. This was a young girl with choroidal osteoma with CNV. So you can see this OCT-B scan shows a choroidal osteoma with IRF. And this is the octa image showing CNV net. The girl was injected with injection Eylea, and after 6 weeks, there is some regression of IRF. Though the CNV net doesn't regress much, the injection was repeated at the stage. And at the stage of 12 weeks, you can clearly document some regression of this CNV net. So this is the beauty of octa. You can actually study the depth of vascular disruption, the regression of CNVs, which are not to be documented by any other imaging modality. So the take-home message for me is that it is a non-invasive, rapid image modality. It shows multi-layered choroidal and retinal architecture, and it is helpful in detecting preclinical disease. And it is a very good patient education tool. It is important in monitoring the disease progression and observe the prognostic value of the condition. Thank you for your patient listening.
So one quick comment from Professor Dudani. Yeah, Manish, please.
It was a very good presentation, Abhijaat.
Thank you.
Just one thing, does the type of the CNV that you see, you showed so many medusa head and the other forms, the fern tree, does it have a prognostic significance?
Yes. So, there's one study, sir, in which out of these 5 to 6 appearances which are there, a couple of them claim that yes, there is some prognostic significance. If that becomes a a pruned tree or a branched pattern, then that has a better prognosis. A medusa head has a good prognosis. But however, if it becomes entangled, the entire area of CNP increases, and that tends to have a poorer prognosis. But still, a research study has to be done involving all the types.
So one question I had, Abhijaat, is that which is the machine you're using, by the way?
So I'm using Hewitt's, and images from in this PPT are from OptoView also.
OptoView also.
Yeah.
So I wanted to know, supposing you have a CNVM which is documented on Octa.
Yeah.
there is no intraretinal or subretinal or fluid there. Will you treat that like how we call as a octa CNVM, which is not clinically evident?
Yeah. So the thing in that is, I also take in account the age of the patient, the prognosis, is there presence of a scar there or not. If there is no scarring, then yes, I will go for a treatment and document it. So after one injection, we can do another octa image.
True.
And if it shows some regression, then yes, why not go for a treatment?
Yeah, but the patient is 6'6" when he doesn't have IRF. Or
If the patient is 6'6", I don't touch it.
Okay.
I don't touch it.
Yeah, that's a good thing. So I think you don't treat the octa, I think.
Yeah.
Still, you have to treat a clinical OCT which is showing IRF, SRF or some fluid in one of the components.
So
Am I
in
right?
all my presentations, sir, I say that yes, I am talking about this modality, but you need to treat the patient and not the investigator.
Great,
too.
great.
I just for the entire panel, I'm just throwing a question. If you have an octa and the patients, if you have a CNVM, which you can demonstrate an octa, the OCT as such does not show fluid, obvious detectable fluid, but the patient is symptomatic. What do? Do you say, no, I will not treat? The reason I'm saying is just think about the resolution of an OCT. The lateral resolution of an OCT is 15 microns. The anteroposterior resolution, the lateral resolution on a OCT, whichever OCT, including the best of all them, is about 12 to 15 microns. The axial thing varies, and it can be around 4 to 5 microns. So if there is a fluid which is present, which is say 4 microns, you will not detect it.
Yes, yes.
So if you are not able to detect minimal fluid and the patient is symptomatic, I treat it.
Definitely, sir.
One injection, and I've seen responses, and I get puzzled why the patient responded. But then if you look at the pattern of the octa, you will see there is a maturation of vessels. The maturation of vessels can be identified, and that is important because we are not seeing any leakage, but the maturity of the vessels can be made out.